Good morning, everybody. Good morning. Good morning. We're here to talk about food. So you better have had enough of it today. Welcome to this session on scaling the response to global malnutrition, and specifically looking at how to partner with households and communities. That's what we're here to discuss. Of course, malnutrition is a big challenge for all of us. And let me start by just framing this before I introduce our excellent panelists. The first thing to say is if any of you has followed up with the World Bank Human Capital Index, human capital can be classified as the potential for you, for a child born today, or for anybody else, to discover their full potential in nation building, in prosperity, by the time they're 18, based on what is built in their life by the time they get to 18 years. And the core principles around the Human Capital Index are two: education and health. Basically, the Human Capital Index by the World Bank says that you need to reach 18 when you have 100% of your potential, meaning you have had good health and good education. And good education may be defined as at least 14 years of education by the time you get, 11 years of education by the time you get to 18. But also about how much health you've had. And that health is related to, one, your nutrition in the first 1,000 days. How well were you fed in the first 1,000 days? Breastfeeding, what you ate, was the food balanced? But also, how did you suffer from diseases like malaria, like pneumonia, like anything else that may have taken your time to school away or even eaten into your health potential? Now, those two factors of health and education as a foundation for human potential are dependent on nutrition, because health is dependent on nutrition, how nourished you are. And that's just not for human beings, that's for everything. Planetary, plant, animals, human beings. Nutrition is the foundation for healthy living. But nutrition is also the fuel for education, because nutrition is what assures you of brain development, cognitive ability. So that even as the World Bank measures the years in education and the quality of education, if you are not well nourished in your first 1,000 days, the number of years for education may not count. You may not get adequate education because of your brain capacity. So nutrition then becomes the good foundation for human capital, because it's both on the health and education side. But we know that whereas that is true, we still have millions across the world who are either undernourished or overnourished. And 149 million children under 5 in the world are stunted. About 45 million are wasted. That is, they're too thin for their height, or stunted, they're too short for their age. And we still have more than 37 million who are actually dealing with overweight and obesity. So it's a critical problem. For me, as someone who comes from the African continent, I know that this is severely acute in our continent because of those numbers I've talked about. 30% of children under 5 in the continent of Africa are living with stunting. 30%, that's 1 in 3. And that is not just about a height problem. It's a health, education, and human capacity problem. So it's actually complicated. It's a socio-economic issue. Then you have a big number who are living with overweight or obesity. That's 1 in 4. So these numbers are just to reflect how critical this issue is of nutrition in socio-economic development. But what is the problem? Why is it that so many years on, we know that when you look back in the Roman Empire many years ago and before, the world was dealing with 3 main problems. It was actually hunger, plague, and war. That's what killed most people. And communities would wake up and there is severe hunger, and a quarter of the population is dead. And we dealt with those issues significantly through industrialization, agriculture, and we made significant progress in ending hunger, even during the SDG period. We made significant progress in peace when we started the Age of Responsibility, which is after the United Nations. Now we're seeing the peace is slipping away again from us, but we know that we had made progress. But millions still have poverty that leads to malnutrition, or malnutrition associated with poverty. And that is what we're here to talk about, because I know very well that the reason I'm here is because my mother took her time to ensure I was breastfed, and that she found the right food for me wherever it was around the village. And that's the only reason I was able to go to school and stand here. I always have a story that school feeding for me was important. That I went to school every morning for my early childhood development because there was porridge in school. And I remember one day I was walking to school, and as you do, when you're young and you're in the village, you're 5, 6 years, you're going to school, you wander around. You don't go on a straight path. Yeah? You wander around, you go, you walk, you see something, you see a dog, you chase it, you see something, you stop. And I saw something, I saw a fruit that had fallen off by a small path. And I walked in there, and the dog from the farm from which I was picking the fruit saw me and chased me. I don't think how much chance a 6-year-old would have against a dog. I didn't have much, so I was beaten on my thigh. But because there was porridge in school, I walked all the way to school bleeding for the porridge. Nutrition is critical. It's important for growth, for education, and for everything else that we do to build our human potential. But this nutrition issue, as I've explained to you, is critically most at a family level. Because the first thing we must never forget is that any animal that sires has the biggest responsibility in nurturing its siblings. That's why I talk about my mother. My mother had the biggest incentive to take care of me. And therefore, at the household is where nutrition interventions are best done. At the household, because that is where the surrounding circumstances, because nutrition is not it's not a clinical issue. It becomes a clinical issue. But ideally, nutrition is just a health issue. You're supposed to be healthy and well-nourished. But we know, as I've given you the numbers, we have millions of children who end up with malnutrition, both under and overnutrition. And those may need to be identified early and for intervention to be done. And therefore, the household is where, because the children who are malnourished or have malnutrition will not walk to a hospital and say, hey, I am malnourished. Please treat me. They will be at home with their families, meaning that those who have malnutrition are best identified through a partnership with communities and households. That is our entry point for this conversation, to say how is it that we can build better partnerships with households, with communities, to ensure an end to malnutrition, to global malnutrition, through societal and household and then clinical partnerships when they are needed. And we have, of course, to thank our partners, Abbott, for making this happen. And with us are practitioners who work at the community level, but also researchers and scientists to tell us the linkages in terms of what we are doing at community level, what tools and innovations are needed to ensure that we succeed. So allow me to call our distinguished panel up here, one by one. My name, as I'm a moderator, is Dr. Githinji Gitahi. I'm the Group CEO for AMREF Health Africa. And AMREF Health Africa is Africa's largest indigenous health development organization, headquartered in Nairobi, working in 40 countries and integrating nutrition within our maternal and child health work, water and sanitation and hygiene work, integrating all that in everything that we do, including integrating it in vaccination work. because that's where actually most of these issues are dealt with. So please join me up here, and please give them a big clap as they come up. Dr. Eric Mock, please come up. Dr. Eric works with the Kenya Medical Research Institute, it's the Center for Global Health, and he's Deputy Director there from Kenya. I would like to call up Oscar Kambona Ayoma, again, Minister of Public Health and Sanitation in Kenya, but working, please come up, please clap for Oscar. Oscar is Assistant Director for Nutrition and Dietetics. Because health is a devolved function in many countries, Oscar works at the devolved level, what's called the county, and therefore has the experience of implementation. Third, I would like to invite up Dr. Manasseh Wandera, my long-term friend, Dr. Wandera from Rwanda, and Dr. Wandera is Executive Director of Society for Family Health, which is working in several countries and based in Rwanda. Another practitioner, actually I heard Dr. Wandera calling her the healer. She is a nurse. This is Anne Abela. Anne, please join me up here. Yesterday, Anne works as a nurse in something called a health post. A health post is the lowest health facility level in Rwanda, and they are now second-generation health posts because Rwanda has kept on improving them. It's Rwanda government's policy and plan and strategy of bringing health services closer to the people. And those health posts are run by the government, but some of them are run by individuals with partnership by the government. Anne is an entrepreneur who runs a second-generation health post in Rwanda. And when we asked her, how is it going? She said this month alone, between 1st of October to now, she's delivered 15 babies at her health post, or assisted 15 mothers to deliver at her health post. A big hand for Anne. And I would also like to invite Dr. Raisa Sogo from the Public Health Institute, and she is the Director of Human Nutrition. And to all of you, because this is actually an education symposium, you're also part of the public. So we're going to come back to you and ask you, what do you think about this? So you are all here not just to ask questions. Okay, good. Welcome.
Thank you.
And we are going to have a kind of, what I would say, an informal conversation. So we had a meeting with the panelists and we agreed no difficult terminologies like anthropometrics and those kinds of things. We agreed to just have a conversation, isn't it? So let me start by asking Dr. Eric from the Kenya Medical Research Institute. So, Dr. Eric, you've been working with, was it Oscar Kambona, actually? Let me start with the field, then I'll come back to KEMRI. Let me start with the field. So, Oscar, you work in CIR.
Right.
You've heard the numbers that I've read on stunting, wasting. How big and how challenging is the malnutrition challenge in CIR County? I think it's about 1.something million people in the county. So Kenya has about 54 million people. The county that Oscar is working in is about maybe 1.3, if I'm not wrong.
1.13 million.
Yes. So how big is the challenge of malnutrition and how are you addressing it? And you can tell us the department you're working in and the government you're working in at the county level. How big is the problem and what are you doing about it? And also feel free to tell us your experiences in the field.
Yeah, thanks a lot, Dr. Gidinji. As you've heard, my name is Oscar Kambona. I'm a public health nutritionist working with the county government, the Department of Health. In that particular county, we are talking of a population of 1.13 million people, with children 150,000 who are under 5 years. What's the magnitude of malnutrition? In terms of stunting, we are a little bit above the national, because the national is 18% who are stunted. At the county, we are at 19.2% who are stunted. It may sound low in percentage, but then convert 19 0.2% of 150,000 who are stunted and are living human beings, then there's a problem here that we need to mitigate. In the county, how we then approach this situation based on our strategies. So we are forced to rechange the strategies. The first strategy was to wait at the facility amidst the low human workforce for population ratio. In this, it was not working out, and they were not coming to the facility. And the county, through the political goodwill and the executive, invested heavily in community health workers. That gives it 100% coverage in terms of community health promoters, and therefore that became our basis to reach and download the basic nutrition education together with the other sister partners to help us initiate the process of turning it from knowledge to practice in terms of improving their dietary diversity.
And are you finding success, or how are you measuring success? And how are you enabling these community health promoters to actually do their work?
Thanks a lot.
Could you probably explain how they're structured? And how are they? Are you paying them? What are they doing? How are you enabling them to actually achieve these objectives that you're setting for them?
Yeah, thanks a lot. 2016, 2017, the county fully invested in the community health promoters. By then, we used to call them the community health volunteers. And the county started by reworking on their policies, and after that, they started remunerating the CHWs, the volunteers, on just bare minimal stipend of around 2,500 shillings. And in addition, the county government took the initiative of paying for them their social health by then National Health Insurance Fund. And that in itself was a motivation to the team. So from the facility, we have what we call the community units. And in that community unit, we have 10 community health volunteers or promoters. And each and every one of them covers an average of 100 households. They've all mapped their catchment population, and therefore, just at their fingertips, they know how many of the pregnant women are there, how many of the adolescents we're having, and how many of our children under 5 that are also there. And to finer details on their daily diaries, they have the details of the health and nutritional status of those under 5 to be very specific.
I see. So in terms of the day-to-day life, let's say, let's assume, Oscar, you're a community health worker, yeah?
Yes.
So when you wake up on this ending nutrition agenda, what are the functions you do when you go out? What do you do when you go to the facility? Because a lot of the people here probably haven't experienced that. So what does a community health worker in CI County do when they wake up in the morning regarding nutrition?
Thanks a lot. All our community health volunteers or promoters have what we call a toolkit.
Okay.
And some of the two things that we'll get, or two equipment that we'll get in the toolkit, one is the Salter scale, supplied both by national and the county.
That's for weight?
That's for weighing the weight. And then the second crucial equipment they're having is mid-upper arm circumference tape.
That is that thing, like the tailor's thing that measures around here?
Right.
Okay. Okay, so do you have one?
Yes.
You have one. Okay, so let's assume you are a community health worker right now. You wake up and you are working at the household. You have 10 households, okay?
Right.
So you visit the household. They don't come to you. You visit the household. And then you do the weight, and then you use that measure, the tape.
Yes.
Yeah?
Yes.
Who is willing to be a household here? Okay, there's a household there. There's a woman. So Oscar, please give Oscar a mic or walk with him. Go and visit that household and do a nutrition assessment.
Thanks a lot.
Who has the mic to follow Oscar? Yeah, yes, there you are. Okay.
And in that household,
This is a rather big household. The
Yes.
the fertility
So,
rate here is very
in
high.
this-
But, so
in
please
this-
go ahead.
in this community, we're very specific to this household because this household is falling under my catchment area. It's very interesting to go into this household because, number one, this household falls into my day's schedule of activities. So when I go there, I first of all have to seek the permission to get into that household. So, Hodikai, in the local language, may I come in, please? And then you're given the authority. And then you interact first with the guardians of the child because you're not specifically going to handle the child minus the guardian. And then you also, after doing the analysis of the gender power analysis, there's a very crucial person that also needs to know all what is going on. And now that Oscar is a gentleman, and that's the father or the male figure, if he so exists. You're doing okay? How is your family? Today, I will wish to have a discussion on nutrition, and particularly we want to focus on your adolescent or a child who is under 5 years old. And with me here, I have what the ministry is using to assess the nutritional status, because at this level, it is the quickest way for us to know how well we are doing in terms of nutritional status. So may I proceed on to get to know your measurements, and then we shall be able to discuss a little bit the implication of the same. Thank you.
Are you scared?
Yes, maybe.
With the assumption that she is an adolescent, then this is the mock tape that will take and is age-specific among the adolescents up to 18 years of age. And therefore, I will request her to stand, feel more relaxed as I take the measurements. And I will be using the hand that is less active. So that's the left hand she has already proposed. And I'll check on the extremes, check on the bones. So are you feeling the bone? I'm touching the bone here. Then I'll put the measurement, the green area marked green there. Oh, you turn around.
Okay, come up here. Come up here. I request. We are now outside the house.
So you have to be on.
So yeah. So from there, we are discussing, and are you feeling the bone there? Then I'll again make it at 90 degrees, bind it at 90 degrees approximately, but I will request you put it all like that, so then I get the maximum length, and out of that, I'll get the mid of the arm. We're together all up to that point. Then I'll tell her, relax. I'll put a mark there, just relax your hand, and then she's already confided to me her age. So if it's 17 years, then I'll look at the side that is indicating the years, which is now the 17 year on this other side. And then I'll take it around. And it's not intrusive. Just feel more relaxed, put it like that. And I'll get, for the confidentiality and the purposes of the Data Act, I will not share with you the finding. But
Thank you.
we will go now into the two measurements here. One is the measurement in terms of centimeters, and I will tell her, you are these centimeters, and I will measure it according to the threshold for her age category. Secondly, I will go to the color coding. And this has categorized the disease score in terms of measurements. So as a health worker, if it's in a situation that she needs more critical nutrition service, then I will refer to the facility. And at that facility, I refer her to, I'm attached to it. So she will get pretty fast service in getting her nutrition rehabilitation. Now that is the first referral. The second referral is after the rehabilitation, back to the community. So that's now under me in my diary. How was the assessment? Thanks a lot.
Do I need weight loss pills? Do I need weight loss pills?
She wants to know whether she needs weight loss pills. We don't know because we were not told.
Thank you very much.
Please clap for
Eric. Thank you very much, Eric.
That was really good, really cool. Eh? So this is what community health promoters are doing when they go to the field. And you made an important point about, of course, the respectful engagement that happens at the household, which is very different for communities when they go to big health facilities, where they feel there's no respectful approach. But we have the interfaces, like Oscar has said now, between the community health workers. When they refer, they get the patient, they refer, they'll end up in a facility. So I want to hear from Anne, because Anne is a nurse, and Anne actually receives now some of the ones who are referred by the community health promoters and the community health workers, and they come there, and of course, Anne's health post is not only for malnutrition, it's dealing with maternal health, it's dealing with pneumonia, it's dealing with everything, because she's running a health post as a health facility. So Anne, listening to Oscar, and from your own experience in Rwanda, what would you like to tell us about your work and how that relates to what Oscar has just demonstrated here?
Thank you very much. But I apologize, I want to talk in French.
No apologies, actually. We are the ones who need to apologize to you for not understanding French.
Merci beaucoup, Monsieur Oscar.
If you permit, I will translate for Anne whenever she prefers to speak in French. And Anne greets you all and thanks Oscar for the introduction.
Vraiment, je suis ravie de votre démonstration.
She's pleased by Oscar's demonstration.
Comme je suis à la base périphérie des soins de santé primaires,
as her work is based in community at the lowest health access point,
la poste de santé, c'est un organe parmi l'organe de santé.
The health post at which she works is just one component of the health system.
Bien sûr, c'est la périphérie parce que c'est là où on doit commencer à se faire soigner.
She works more specifically in the rural area, which is where most of the population in her country reside.
Là, à ce niveau, il y a un paquet d'activités minimum que nous devons dispenser aux patients ou bien à la communauté.
At this level, there is a packet of services that such clinics such as hers work to deliver to the community.
Parmi ce paquet d'activités que nous devons dispenser aux patients,
as part of this packet of activities,
nous pouvons citer d'abord que nous sommes en charge de faire le triage des maladies.
One of the first responsibilities is triaging what comes in at the health post.
Dont les maladies, certaines sont des maladies urgentes ou bien des maladies qui sont curatives.
Ranging in diseases that are urgent and others that are curative.
Mais il y a d'autres aussi qui ne sont pas qui ne peuvent pas guérir, donc ce qu'on appelle maladie chronique.
And they also, of course, receive a lot of chronic illnesses.
En plus de ça, nous devons aussi gérer selon les âges.
Another component of this triage is age-based.
Tout ça, ce sont des activités qui se font au niveau de la poste de santé.
All these are some of the activities that are conducted at the clinic level.
Mais pour ne pas aller loin de notre sujet,
not to stray too far from the original subject,
nous avons aussi les charges de poursuivre l'état nutritionnel de la communauté.
We're also tasked with the pursuit of the nutritional status of the community that we serve.
Je dis bien la communauté parce que ça va aller jusqu'à tout le monde.
And she says community because it goes beyond those who they see at the clinic. It really includes everyone.
OK. Sans pour autant vous prendre beaucoup de temps,
Without taking too much of your time,
je vais d'abord dire quelque chose à propos de la nutrition.
I'd like to make a statement about nutrition.
Pour faire le triage ou bien le suivi de l'état nutritionnel,
Enabled to do both the triage and the follow-up of nutrition,
nous travaillons étroitement avec les agents de santé communautaire.
we work very closely with community health volunteers.
Pourquoi? Parce que ce sont eux qui sont plus proches de la population.
And that's because they are the closest tie to the community.
Et ce groupe ou bien cette catégorie de personnes,
This group of health personnel,
ils sont choisis ou bien sélectionnés selon que chacun va aller d'une maison à l'autre et connaître leur santé.
are selected specifically because they know the area and they understand the health difficulties.
Ainsi, ces agents vont découvrir ou bien savoir et gagner la confiance
And in so doing, these are people, agents, professionals who are able to win the confidence of the communities that they work with,
de la communauté à sa charge.
the communities that they work with and that they're tasked to support.
D'où alors, si une dame devient enceinte et qu'elle sait déjà qu'elle est enceinte,
Meaning that if a woman in the community is pregnant and knows that she's pregnant,
là, le travail de l'agent communautaire de santé commence.
the work of the community health volunteer really begins and kickstarts
Parce qu'elle ou il va faire un petit mot
because he or she, the community health volunteer or agent, will write a reference,
de transfert pour nous envoyer la dame enceinte.
a reference from the household to the clinic to ensure that the connection has been made between the two.
Pourquoi ceci?
And why this?
C'est pour que nous puissions commencer très tôt à assumer la santé, à assurer la santé et de la mère et de l'enfant qui va naître.
And that's because we want to begin the process and the connection as soon as the mother is pregnant.
La maman va venir premièrement pour que nous puissions confirmer que réellement elle est enceinte. Parce qu'on peut avoir les signes de grossesse alors qu'on n'est pas enceinte.
As a first step, the expecting mother will come into the clinic where we'll be able to verify that she is pregnant, because often you can have some of the symptoms of pregnancy without actually being pregnant.
Alors, nous allons faire les examens, le test de grossesse,
So we follow up with a plethora of exams, including the pregnancy test.
une fois que le test devient positif,
And as soon as the test is positive,
nous commençons alors avec la consultation prénatale.
we'll begin with prenatal consultations.
La consultation prénatale aussi a ses objectifs.
And this consultation has its key objectives.
Bien sûr, parmi, c'est la suivi de la mère pour que nous puissions assurer la santé nutritionnelle, mais aussi
Including the follow-up for nutritional purposes, but also
nous allons aussi faire le dépistage de quelques maladies nuisibles à la santé de la mère et de l'enfant.
but also a plethora of other illnesses that would affect both the mother and the child,
Parmi eux, le VIH,
including HIV,
la syphilis,
syphilis,
toxoplasmose et whatever.
toxoplasmology. And what was the last one?
Toxoplasmose. Et ainsi.
Wow,
Okay.
that's a mouthful.
Ah. Après ça, nous recommandons à la maman le calendrier de visite de consultation prénatale jusqu'à l'accouchement.
And from this point, we work with the mother around the birthing calendar and the pregnancy process.
D'une façon, je dirais ordinaire, mais de convention mondiale de l'OMS.
In a context-specific way, but based on World Health Organization guidelines.
Aujourd'hui, les visites doivent être 8 de la conception jusqu'à l'accouchement.
And from conception to birth, there are about 8 mandatory visits.
Passons à autre chose. La maman vient à consultation, après elle va accoucher.
And encore, s'il te plaît.
Elle passe de la consultation jusqu'à l'âge de la grossesse pour accoucher.
Okay. And she goes from consultation all the way to the endpoint of the pregnancy until birth.
Durant toute période, la maman reçoit les conseils, l'éducation à la santé concernant la nutrition qui doit maintenir sa vie et la vie de l'enfant.
And during this time period, she receives consistent counseling around the key components of both her health and the health of her child.
Au moment de l'accouchement,
And at the point of birth,
l'enfant est né.
the child is born.
Directement, nous recommandons à la maman de faire téter son enfant pour commencer à maintenir maintenant l'enfant à l'extérieur du ventre de la maman.
And as soon as the child is born, we work towards breastfeeding as a first step in maintaining the health and nutrition of the child.
On saute. Tout ça, nous essayons de partager les idées et les informations avec les agents communautaires de la santé.
And this process is also a learning process for community health volunteers.
Excusez-moi un peu, revenons un peu en arrière. Dès que l'agent communautaire nous a envoyé le papier ou bien le transfert de la maman,
And going back a step to when the community health volunteer conducted the first referral for the pregnant woman,
nous devons lui rassurer que la maman a été reçue en faisant le contre-référence.
we have instituted a counter-referral process to return to the community health volunteer and validate the process, the work that he's done, and the referral that he's made.
Et la maman va ramener encore le papier chez l'agent communautaire.
And the mother's given this piece of paper that connects the community health volunteer and the clinic.
Et à partir de là, elle aussi saura que la maman est enceinte, elle va la suivre de près.
And from this point forth, the community health volunteer also follows the mother at the household level very closely.
Pour bien sûr savoir que la nutrition sera bien maintenue.
And part of that task is maintaining the nutrition of both mother and child.
Des fois, nous pouvons planifier, nous aussi, pour aller réellement visiter si les conditions exigées sont réunies.
There are also visits whenever possible by clinic staff to the household in order to ensure that the environment in which the mother is living is able to sustain some of the key indicators that they're looking at.
Pour dire vrai, l'existence des agents communautaires de la santé nous a donné une solution meilleure pour la prise en charge de lutte contre la malnutrition dans la population.
The existence of community health volunteers has given us a primary pathway to the population and a primary connection to the population in terms of dispensing health.
Je le dis bien pourquoi, parce que
And I say this because
ce sont eux qui vont savoir que la maman, que dans la communauté, il y a des potagers.
Because the agents are the one who know the community, everything from knowing where water will come from.
Si nous avons conseillé de garder, élever les poules pour avoir les œufs.
They're the ones who are able to support in small endeavors such as raising chicken to have eggs for the household.
Ils sauront bien que les œufs sont en train de consommer au niveau de la famille et ne pas être vendus.
And they're also able to confirm that anything the household produce is primarily consumed by the household before any kind of sale or distribution.
Même si, s'il y a le lait des vaches, parce qu'il y a des moments où on peut élever les vaches à côté.
And that also applies to cow's milk, for example, in the household.
Que ce lait est consommé,
What is being consumed,
ainsi que les légumes du potager.
and also vegetables from home gardens, for example.
Passons à autre chose.
On to additional matters.
Parmi les services ou bien les activités que nous dépensons au niveau des postes de santé, le prime, l'activité qui prime,
Including, in terms of the services that they provide at the health facility, one of the key prime activities
c'est l'éducation à la santé.
is health education.
L'éducation à la santé englobe beaucoup.
Uncle?
Englobe beaucoup de choses.
Health education encompasses quite a lot
Parce qu'il y a beaucoup de sujets. que
because
nous
there
entendons.
are a vast variety of subjects.
Parmi les unités de l'éducation à la santé, on a l'hygiène.
Including hygiene,
Parce qu'une hygiène défectueuse peut être la base aussi de la malnutrition.
because poor hygiene can also be a basis of malnutrition.
On peut avoir tout le nécessaire pour assurer la santé, mais le manque d'hygiène va provoquer la malnutrition.
You can gather all the right conditions food-wise for good nutritional status, but without hygiene, that pillar falls apart.
Pour être un peu large, c'est que si on mange les saletés, ça va se coller sur les vésicules, bien les vésicules intestinales, là où les nutriments peuvent passer, s'infiltrer pour aller à l'organisme, dans l'organisme.
Poor hygiene can destroy the food intake that individuals have.
Yeah.
Alors, on devient malnourri alors qu'on avait tout.
And in which case you find yourself malnourished even though you are faced with enough food at the household level.
Wow. So, Madam Anne, don't we wish every village an Abela of their own? Please give a big clap. Because it is so integrated in what people are doing every day that actually this is where we keep saying that health is made at home. Hospitals are garages for repair when things go wrong.
Absolutely.
But the closer you are to the community, the more of the home health building you are, like Anne Abela. Thank you so much for this process, and I know you'll share more, but thank you so much. I wish every village. I want to come to you, Manasseh, because of course you are in this whole ecosystem.
Yes.
With celebrated health workforce like Anne, how is this linked to the national policy? How is it that you ensure that Anne's work continues and continues to actually develop the socio-economic status of households in Rwanda? How is that linked to the policy level, Manasseh?
Yeah, thank you so much, Doctor. First of all, I think this is a wonderful opportunity to be here to listen to different people with different experiences and expertise. So how Anna's work is linked at the national level is really the national level providing policy framework that is enabling, that is making it easier for community health workers, for people like Anne, to be able to have appropriate information, tools, guidelines, and support and encouragement to be able to deliver. For example, Anna talked about the whole journey of the community health workers being able to educate, to sensitize, to follow up, to really make sure that people at the household level, and I love your statement, health is made at home. Hospitals and facilities are garages for repair. So making it at home they need to know that they are champions and there is a policy framework. And the government of Rwanda since 2000 has really helped frame proper guidelines to really fight the problem of malnutrition. Just for your information, since 2000, the levels of malnutrition and stunting in Rwanda were really very high. For example, stunting was over 55%. That is so much. It has since gone down up to 35. And the plan is actually in the next 5 years to push it up to 15 and eventually to 0. You cannot do that without proper guidelines, policies, environment, and tools, and a proper pathway with facilities like the one that Anna is running to be able to screen and again support. So it is really a back and forth movement of ecosystem of support.
Wow, so it is linked all the way with
Yes.
the government system. So
Yes.
Anne and the community health workers have support within the policy framework
Absolutely, and tools.
and tools. So this policy conversation, maybe I can come over to Dr. Mwok, because you're working with the Kenya Medical Research Institute, KEMRI. And policy making, as Manasseh has said, has to be dependent on evidence. So relating what you're hearing from Rwanda, what you've heard from Kenya, what would you comment on the role of research in ensuring that we have continuous improvement of the service delivery that we're doing? So over to you, Dr. Moore.
Thank you, Dr. Gitai. I think, just as my team puts it, policy framework is the key. And KEMRI's mandate is research and innovation. The idea, when we talk about innovation, we mean innovating processes and tools that makes it possible for us to navigate around diseases and ill health, just like nutrition. And I want to go back to my very own experience as a researcher. I'm actually a trained laboratory scientist, and I'm an immunologist by training. But the look of things, as I grew up as a scientist, I have looked at several data sets and seeing lots of pointers to causes of death being associated with malnutrition. When you look at child mortality studies, malnutrition is still in the top 2 causes of death in children. And when you look at even other data, even from adults, and when we look at it from a different point of view, even secondary malnutrition, once somebody gets sick with malaria or any form of infectious disease and they're taken to the hospital, the medical practitioners are concentrating on malaria, are concentrating on HIV, but the person is wasting. There's a form of malnutrition that is going on. So we can clearly say, with the statistics that you talked about, that it is a problem that we seem to close our eyes to. Now, back to the Kenyan system, we all know that health is devolved. It's at the county level, and that is where the action is. And the Kenyan government has done as great by moving forward to put in up to 100,000 community health promoters, community health workers, and this forms a very affordable for us to actually manage malnutrition through innovative ways that research and innovation has put in place. One of which Oscar demonstrated very well. And that is part of what we hope is going to push malnutrition to levels that we really want it to be. Yeah.
So, what was demonstrated by Oscar,
Yeah.
have you been involved in any research improving the way we monitor malnutrition at the community level?
Exactly. So this tool is actually being used in Siaya County plus the neighboring counties. And that takes me back to what we call the policy-making process. Our system works through technical working groups, which again depends on evidence to make decisions into policy. That evidence is actually collected from the household level, the way Oscar had demonstrated, so that the policy is made based on what is practical. So for the last 3 years, we've been using the tool that Oscar demonstrated. I don't want to call the name because you said we need to be as simple as possible. The 2 tapes that we saw, and it has several advantages. And just to mention but a few, as he was finishing the household visit, he said he was making immediate referral. That saves on turnaround time. Apart from that, the tape also takes care of babies from 2 months to 18 years. And we all know from age 14 what happens. There are so many changes that happened in the physiology of individuals, and these, for a very long time, were left out. So this is something that Kenya Medical Research Institute has experience with, not in one side here alone, but we are snowballing with the neighboring counties. Yeah.
You know, I was in medical school. I joined medical school in 1990. And when I joined medical school, we went to community programs. And we used to do mid-upper arm measurement. So how different is this from that? Because you're actually indicating that what Oscar is using is new innovation. So is it the same as you? It doesn't look familiar to me. When I was in medical school, I don't think we had all those details on it. So how different is this from what I used when I was in medical school, Mwok?
Yeah, so what you saw during the medical school was a MWAC measurement that would then go back to calculate and get to know whether the person needs a referral or not. But you saw Oscar with a second tape, the Z-score. So it means Oscar, right at the floor of the household, is able to make an informed decision for a referral at that point. That is a huge difference in terms of turnaround time.
I see. Okay. There's something I want to ask then Oscar to comment on. Because you made a very important point around malnutrition is ignored. So when a child comes with pneumonia or malaria, we treat the pneumonia and the malaria, we don't bother about the malnutrition situation. What we've heard from both Anne and Oscar is the community level engagement and referral for malnutrition. But if a child does not come through our superstar community health workers and referred for malnutrition, and they just show up with malaria, are there integrated systems, Oscar, at the hospital, at the facility is malnutrition assessment integrated in malaria treatment or in pneumonia treatment if somebody did not come through the referral system that you talked about? Or how is that? Or is there a gap?
In terms of human resource and capacity, there's a gap.
Okay.
So you may not get to 100%.
Right.
Secondly, we perceive that the nutrition is undernutrition. That thing. But based on the population-based survey that we had nationally, the overweight is also emerging, right from children state. And then there's also another very special category here that is faced with many calamities, and that's the adolescents. So this mock tape, to be specific, is able to pinpoint some of those extremes in malnutrition, and age-specific.
Thank you. So is this mock tape available at the facility, or is it only available with the community health workers and promoters?
It's available at both levels.
So the nurses also have it?
Yes, the nurse also have it, just to counter-check, but the congruency is to 100% as done at the household level. So it's just a confirmation. And also, it gives the community health promoter a chance to counter-check whether the same was taken in the mother-baby booklet. And that is the medical history for the mother. So when it goes to the facility, the same is checked, and then the continuum of care, nutritional care, is availed.
So, Anne, yes or no, do you have a MWAC tape at your health post?
We have.
This, the new one you showed, this one?
Yes.
You have this?
Yes.
You're really advanced, aren't you? Okay, thank you very much. So, Raisa, you work with Public Health Institute. You've been involved in development of some of these innovations. So maybe tell us a little more about this particular innovation, because what I used is very different from what has been shown by Oscar this morning. So could you comment on that?
Sure.
Yeah.
So the MUOC tape, the one that most of you are familiar with, is a plastified tape that's used, as you had displayed, to measure the mid-upper arm circumference of a child. And it's a tape that began around the 1950s and primarily in humanitarian settings. And since then, there's really been a global call to innovate on this tape to provide additional information on nutritional status. So the original tape really just gave you an understanding of a child's status in terms of nourished or malnourished or undernourished. And what this new tape is able to do is provide an extended amount of information, beginning with what Dr. Muak shared, which is the extended age range, where the original MUOC tape went from 6 months to 5 years of age. The new MUOC Z-score tape goes from 2 months to 18 years of age. Also, as Oscar mentioned, the original MUOC looked at undernutrition, whereas the MUOC Z-score tape is able to look at both undernutrition and overnutrition. The last component is really the Z-score, which, as Eric shared, is a key component of understanding where a child stands in their nutritional status in a normal distribution at a population level. Normally, you would have to take the height, weight, and look at the age of the child, calculate the MUOC Z-score before you're able to perhaps counsel a household or refer a child. The Z-score tape already gives you that information in real time, in person, so the community health volunteer doesn't have to make 2 or 2 trips, but they're able to right away begin conversations at a household level.
Wow, thank you. Thank you, Reza. Let me ask you an unfair question. How, many of us here, all these people are very learned, the people you see here in this room. So they use BMI. Mm-hmm. They use BMI, So what's the relationship between all these and BMI? Do you want to comment on that?
That's a great measurement, but in real time, most community health volunteers are unable to take BMI at household level. And in this conversation, we're really centered on seeing how we can make the most impact at household level. So when you get to the clinic, you're able to look at BMI as another factor, as another component of the nutritional status of children, but at the household level, it would require perhaps too much effort to devolve this to community health volunteers.
So this is a community health system strengthening innovation.
Yes.
Fantastic. Thank you very much. Thank you. Now, I want to hear from our audience, both in terms of a question or a contribution. So if you want to add to this conversation, you can do so. Or if you want to ask a question, you can do so. We have a mic. Let us start with our household member, and then we come back to you. Yes, over to you. And if you have directed a question to anyone in particular, please you say so. If it's general, say so. Number 2, introduce yourself.
Okay, thank you very much. My name is Temitayo. I'm from Nigeria. I work with eHealth Africa. My very interesting conversations and presentations. My question is around the referrals. Once you've got into a household, done the assessment, and are referring to the health facility. In Nigeria, where I come from, there's that challenge to making sure that the referrals are sort of completed. So you could refer someone to the facility. How do you ensure that they actually got to the facility, they received those services? So the question is that a challenge you've experienced, and how do you mitigate or address that? Thank you.
Thank you very much. So we'll comment on incomplete referrals, and I think that's very good for Oscar and also you want to comment on that. Incomplete referrals, how do we manage that? Yes, sir.
Thank you very much. My name is Dr. Shamsuddin. I'm from Nigeria also. I'm the Executive Secretary, Katsina State Primary Healthcare Agency. In my state, similar to county, we have over 10 million people, and the rate of malnutrition is quite very high. The stunting rate is up to about 40%. And this is fueled by a lot of, insecurity. We have a lot of banditry, a lot of, kidnappings, and people have been displaced from their settlements. We also have this, especially this year, a lot of flooding. People could not farm, so this has really complicated the issue. What we have tried to do a little bit differently is we have this mother-led work where mothers are taught how to do the mid-upper arm circumference by themselves. We have also what we call the CMAM, Community Management of Acute Malnutrition. We have the centers, about 150 or so. Then we have the OTPs and children with severe acute malnutrition. They are placed on what we call RUTF, ready-to-use therapeutic foods. It's quite expensive, very, very expensive, and is prone to pilferage. And so what we try to do is to strike a balance between, prevention and treatment, so as to address the situation. I believe what we need to do more is to strengthen intersectoral collaboration. Focusing on nutrition alone from the lens of health sector is not going to solve the problem. We really need to strengthen intersectoral collaboration, education, water supply, agriculture, and others. We need to do that so as to, address the issue of malnutrition. Other key household practices, just like you have mentioned, the hospitals are the garage for repair. We need to imbibe that exclusive breastfeeding, complementary feeding, personal environmental hygiene, and so many others. So I believe, and even now, rising inflation, I don't know for other parts of the world, but in Nigeria, inflation is up to about close to 40%. So the burden is really, really high, and I believe we need to do something urgent to address the situation. Thank you very much.
Thank you very much for that contribution. Okay. So let's hear that, and then we come to a round of answers. Yes, please.
The panelists and the moderator. My name is Israel Balogun. I'm currently a PhD student from the University College London. I also worked in humanitarian setting. However, my main concern is the tracking mechanism. You might have everything in place. How do you track it to monitor the progress over time, to see how effective some of the suggestions has been made, recommendations that have been made during the referral stage, how effective have they been following that incident? The second thing also I would like to ask is the issue of malnutrition and disability. I'm a person with disability, and I also understand that, unfortunately, especially I've worked in Ethiopia, Somalia, and I go to Kenya regularly. I see a lot of, we have poverty. In Africa, I'm from Nigeria also. We have a lot of poverty. How do we merge the two so that you work towards adequate nutrition to prevent poverty-related disability due to malnutrition? Thank you so much.
Wow. Thank you very much. Let's start with those. So we have quite a few, and I would like, you don't have to answer all of them. So we have one around incomplete referrals. So who wants to take that? Oscar? Yeah. Okay. If there's something he leaves out that you remember, you could add. Then we have the question of tracking. So, Mok, do you want to talk about that?
Yeah.
Yeah. We have the question of, this question of very complicated around malnutrition and disability, and ending poverty-related disability, malnutrition and poverty-related disability. Who will take that?
Partially.
You'll take that as well?
Partially.
Okay, good. So let's start with those, and then we hear. Over to you. Let's start with Oscar.
Yeah, thanks a lot for the wonderful questions. It gives an opportunity to highlight what we do on the ground there. In terms of referral, the ministry has put in place the forms that allow for tracking. The Ministry of Health, MOH 100. It's given at the household level. Now, when I'm given at the household level, when I go to the facility, I'll get to leave it there. But again, another thing happens at the facility. There's another permanent register, which is MOH, and still Minister of Health is a permanent register. Even if you go right there, for those who were born 30 years ago, I'll still get my details. The MOH 705A and 705B, that's for children and for over 5 and under 5 children. So then we also have community-based information reporting, MCOL. We have, again, facility reporting through community health system, and that will be summarized in MOH 515. Now, at the end of the month, all the community health promoters meet at the facility level to review the attendance level and any gap realized, and if that person falls under my catchment population, then that's my next task on finding out what really happens on that. So it's on the basis of that data that they are having their monthly facility-based reviews, performance reviews. Do I go to the next?
Yes, please.
And
Okay.
maybe to add to what Oscar has shared,
Yes,
in terms of tracking, in a way, community health volunteers do also serve as trackers because they know who in the community perhaps has received a referral, so they're able to backtrack and check if that referral was followed up, both at the clinic and at the household. And also during COVID, the idea of family MUWA came up because during COVID, community health volunteers were unable to go as regularly into households. So some households were actually taught how to use a MUWA Z-score tape, which meant that the mother was able to track her own child in between the visits of community health volunteers. So these are two additional components of tracking that are embedded in the system.
Thank you.
Thank you. Yeah.
And remember, there's also what we call mother-baby booklet, MOH 216, which has all the details of what was done in the previous visit to the hostel. And the CHWs, the first thing they ask about is that book, the presence of that book, and then go through it, and then they advise. In terms of, allow me to use the term delayed milestone. And also to say that our community health promoters have been trained on a package. One of the package is called Integrated Community Case Management, which malnutrition is part of it. Now, the second bit they've been trained on is what we call the nurturing care. We not only do nurturing care at the facility level, but we involve the caregivers on how best they can do it at the household level. In case there's a detection on a milestone, then the referral is now made to the rehabilitation team within the facility. And from there, they are now even able to get other services that they may require with that special condition. So all our community health promoters, in our case, is 2,128. They've gone through that. And also, to make their work easier, they are reporting digitally through their mobile, which partially UNICEF and other partners, AMREF, participated in helping the county procure those reporting tools. So they are already into that system. They just dial, and the data is there.
Excellent. Thank you very, very much. Do you want to comment, Dr. Mwok, on this?
I think that is quite in order. It's a very detailed explanation of what happens.
Yeah.
But let's not forget at the policy level that there are still people who do not go through these processes. And I know you are coming to this, the healthcare financing. How prepared are we to take care of malnutrition at the hospital level? Yeah. This to us is a huge challenge. And it's important that I can take this opportunity to present the Kenyan case, where we have the National Hospital Insurance Fund that is now moving into the social health insurance. And when you look at that package, malnutrition is missing. And that is a huge challenge. And I would want to echo this early enough that we need to either make changes or add-ons to healthcare financing policies within our countries.
No, that's a really important point that actually maybe Manasseh, you could comment on this. How is malnutrition service delivery integrated into health financing in Rwanda?
Yeah,
I think what Dr. Mwok is saying is that there's a challenge there. We have everything else but nutrition services. Somebody talked about RUTF, for example. Who pays for RUTF when it is needed at a clinical level? So, Manasseh?
Yeah, thank you so much, Doctor. I think one of the colleagues in the audience also talked about malnutrition being a multi-sector issue, not a single institution. For example, in Rwanda, us as Society for Family Health, which is a civil society that is working with different ministries to provide information, to provide health products, and to build clinics and also support community health workers, we work with different ministries, the Ministry of Agriculture, the Ministry of Education, of course the Ministry of Health, the Ministry of Gender and Family Promotion. Rwanda has also set up a specific institution called the National Early Childhood Development Agency, and then the Ministry of Local Government. So all those have a specific advocacy agenda and budget implications to support the fight against malnutrition. So really, the issue of policy, financing, and linking it to community and the specific targeted fight against malnutrition is something that needs multiple players. And I really want to congratulate the government of Rwanda and all the partners that we work with. The figures I told you about of how stunting moved from 55% to 35%, and now with a target to 15%, and eventually to 0%, is not something that can be done by a single institution. So private sector, civil society like ourselves, government ministries, of course the Ministry of Finance, heavily involved because they allocate funding for all those ministries, Ministry of Local Government, Ministry of Agriculture, Ministry of Health, the specific institutions, and the all coordination. And actually, maybe for your information and for the information of the audience here, is that in Rwanda, there's what we call performance contracts. Each district is actually tasked to deliver specific results every single year, which are monitored against specific set of indicators, including fight against malnutrition. So measured scientifically and periodically. So really everyone, it is a fight that is really comprehensive and managed by everyone, supported by policy, resources, tools, and the continuous lessons that are picked along the way and improved upon. Thank you.
Thank you. Thank you very much for that explanation. I want to ask Anne in 1 or 2 minutes to say, when the people are referred to you, children with malnutrition or adolescents or women with malnutrition, who pays for the service you give to them? Do they pay out of their pocket, or is there a system that the government has provided for payment of those services? And Raisa will very graciously translate.
Okay, thank you very much. Le service est pris en charge par le gouvernement à travers les mutuelles de santé.
Services are paid for by the government through health mutuals.
C'est-à-dire, le patient ou la patiente vient avec ses problèmes et lui, il va payer seulement 200 francs rwandais et le reste sera couvert par la mutuelle de santé.
The patient comes in with perhaps a plethora of health issues, but will contribute only 200 Rwandan francs, and the mutual will take care of the rest.
Thank you. So how much is that? Oh, sorry, Anne, you haven't finished?
Le 200 francs rwandais équivaut à 1 euro.
200.
Non, 0.10.
It's actually 2 cents.
0.01
2 cents of a dollar.
2 cents, that's what I was going to ask. So it's 2 cents of a dollar.
Yeah.
So that's what the patient pays. And then the rest is taken care of by the mutuale, the health insurance. Fantastic. So this is what Mook is asking, that nutrition services need to be included, and that's policy level. So let me ask, because we have only now a few minutes, then we come to the end of this. So, Raisa, how do you see adoption of technology, adoption of innovation? And maybe you yourself and Manasseh could comment on this, because this is innovation that's being shared here. We are hearing that it works. But how would you chart the path forward for adoption in the public sector, for example, so that when you go to any facility, you actually find it. You don't only find it in program sites, you actually find it in the entire system. How could you reflect on this?
I think partnership is actually key to adoption. And by that I mean the primary partners being the community, but in in any scaling work that you do, you need partnership with the scientific community, you need partnership also with the policy community, and then with perhaps public and private sector institutions that are also interested in innovating. So finding a partnership, a group of partners that are interested in long-term and sustainable investments in health. Actually, I forgot to introduce myself, so I'll introduce myself and then I'll circle back to how this connects to everyone on this stage. Again, my name is Raisa Sorgo. I'm the Director of Global Nutrition and Partnerships at the Public Health Institute. And over the past 5 years, I've had the privilege of working with everyone on this stage. And in the work with Eric Muak and the KEMRI team, it was looking at creating evidence, the kinds of evidence that's necessary to support the creation of policy. So that's one end of this spectrum, one end of creating data that will support policy that's created. In working with Oscar, we've worked on sustainability initiatives and capacity building in community and also at facility level. So strengthening community health workers' understanding, strengthening and updating knowledge for nutritionists and nurses. So that's another component of the partnership that's essential to scaling initiatives and also adding and creating policy at the tail end of that. Another component of that work was actually also creating real-time data at the facility level. So because screening wasn't integrated as vastly in Siaya County, it was harder for Oscar to make a case for nutrition. So having the combination of Oscar at the local ministry and KEMRI as a research institution creates the scientific data to support policy creation. Then of course you have implementers like Anne who are actually doing the work day to day and serve as that connection piece between the healthcare system and also the community. And lastly, I've had a chance to work with SFH in looking at how you integrate nutrition services in over 200 facilities in a country. So that's a systemic level of work and implementation. So looking at scaling up from research that you may have done in one area to understanding how that makes sense on a larger scale. And of course, there's a financial component of that equation. So I think all of these are pieces of the puzzle that are required for scaling and also for creating policy level change.
Fantastic. Thank you very much for explaining that. Very, very clear. So as we come to an end, there's something's been nagging me about. So we talk about each of us here has a job. I think you're paid by SFH?
Yeah, Society for Family.
Yeah, you're paid by FSH. This is private sector, and it's private sector actually. She runs the health post as a private sector, but of course within the public ecosystem. So you pay yourself through entrepreneurship. Oscar is paid by the government of Siaya. Mwok is paid by KEMRI, and you're paid by the PHI, and I'm paid by AMREF. Who pays the community health workers who actually were the link that we talked about? So in Kenya, who is paying them? And maybe just a quick comment from you and a quick comment from you as a last point as we come to the end of this.
This is actually the part, and it relates very well to yesterday's discussion about community health workers and the role they play in primary health care. The Kenyan government has initiated the process of paying community health workers, and I'm intentionally saying initiating the process because it's not 100% done. And yesterday, listening to the statistics, Africa had a target of 500,000 community health workers being incorporated into the system. And our government has promised to do 100,000 within Kenya alone. And to me, this is the greatest fodder that we could utilize to fight malnutrition.
Fantastic. Thank you very much. Oscar, are you paying them in Siaya?
Yes, two-level payment. The national give 50%, and the county government give 50%.
Okay. How much are they paid?
Roughly 2,500 from the county, 2,500 from the national government. However, in the county government of Siaya, remember the social health has been taken care of, so it's a little bit richer in our context.
So it's about $40 a month. $40 a month. Yeah, and that's a big step forward from zero. Yeah. And Manasseh, want to comment on this issue of payment of community health workers?
So in Rwanda, they work as volunteers, but they are facilitated. So the government and the partners and the different organizations that work with them really try to facilitate them, but they are not yet on the payroll. They are volunteers. They do a very good job, but I think it is really something that is under discussion. I think the group and the people and the specific governments are discussing this. It is important that they really get payment for the services. Just like you said, they are playing a critical role. Just like many people who are doing health, it is only the community health workers who are not yet on the payroll, specific payroll. Yeah.
Yes, Anne.
Ce que je peux ajouter, c'est qu'il y a certaines qui reçoivent le support du gouvernement. On donne les bicyclettes pour faciliter leur transport. On donne les téléphones pour faciliter les communications, et ainsi de suite.
Anne adds that although they're not formally paid, they do receive some materials to facilitate the work that they're doing, everything from bicycles to cell phones, for example.
I see. Thanks, Anne, for that addition. Yes, you want to make a comment? Yeah, please give him the mic.
Thank
and
you
introduce yourself.
Thank you very much.
You
I'm
could stand
Alex.
so that people see you if you don't mind.
I'm Alex Mujisha. I'm in charge of partnerships at SFH Rwanda. I'd like to compliment on how the community health workers are paid. So the government has created a platform where they are in cooperatives, and under the maternal child health program, the numbers that they report, the government gives them an incentive that is paid to their cooperative, so they are able to run their economic activities as a package that supports the community health workers. And as I have the microphone, I'll also say that what Anne is doing as a private business, SFH is doing that to ensure that we have functional clinics in Rwanda that do the same job as Anne, so that we can scale up the health impact on the level of the government. So we are happy to be working with the government to scale up the services at the decentralized healthcare level. Thank you.
Thank you very much.
So, moderator, if I may add, on the issue of the cooperatives, really that has become a game changer in the livelihoods of community health workers. Even if they are not on the payroll, the money that they are able to pull together in their cooperatives is able to support them to make sure that their livelihoods are much better. For example, there's an intentional scheme in the Ministry of Health and other partners who are working with them to make sure that whatever they pull together, then they can reinvest in economic generating activities. In one of the districts in Karongi, they have actually put up a big building, a storage building, where they are renting and they are actually getting incomes. So there is actually, even if it is not a direct payroll pay, you can sense that they are very respected, they are very happy, and they are earning some specific livelihoods from their work. Thank you.
Thank you. Thank you very much, Manasseh. I saw a hand that was going up like this, one only because we are at time. No, just one. I had seen it up there. And 30 seconds, we have only 2 minutes.
Good afternoon, colleagues.
30 seconds, 30 seconds. And there'll be no answering. So you'll catch these people after. Yes, please.
Yeah, my name is Said Abdullah Sadat. I'm from Afghanistan. I work for UNICEF as a nutrition officer in emergency. I just wanted to contribute and add, give you a small image about what we do in nutrition, because we have one of the largest programs in the country. We are treating almost 1 million children under 5 years of age who are affected by severe acute malnutrition each year, and around 2.5 million of moderate acute malnutrition treatment. We have 3,500 health facilities that are delivering severe acute malnutrition treatment services there. we are following the integrated management of acute malnutrition package, and it has 4 components. One is the community outreach, as all colleagues mentioned. We have IPD SAM services, OPD SAM services, and also OPD MAM services that treat moderate malnutrition. So there were some missing pockets of children in urban areas, as the focus was on rural area because of the poor economy and other issues. But we realized that there are missing children in the city centers, in the capital, in urban areas, and that was around 205,000 children. So we started urban nutrition program and started treatment of these children at urban areas, as well as we have family health houses that are supported by different donors and UNFPA and others. So that is purely community-based program, community health houses. There is a community midwife and community nurses that are treating malnutrition. We use RUTF for that treatment. But the biggest achievement was that apart from these treatment services, we had development activities that has supported us in reduction of malnutrition each year. Thank you.
Thank you very much. There is a comment from here. Yes, please go ahead. The mic movement. Oh, do you have the mic? Okay, go ahead. Go ahead, since you have the mic, then the mic will come to you. Sorry. Yes.
Okay. So I'm Brigitte. I'm the health advisor for Action Against Hunger, or Action contre la faim, from headquarters in France. I wanted to thank you so much for your speech today and to value so much the work of community health worker. I'm sorry to ask you just one question. I was wondering about the sponsorship from Abbott for this session, because you have mentioned before that Abbott is the one sponsoring this session. I was wondering what the role exactly of Abbott, knowing that there is some controversial issue related to their role, especially for a breast milk substitute and the respect of the code. So maybe you were saying that you may not have time to respond, but just at least to mention it. Thank you.
Okay. So if I got your question, you want to learn more about the role of Abbott? Okay, good. There are people here who can actually talk to you. So someone will talk to you right now about that issue. Yeah? Later, after the session. Yeah. Thank you very much. Yes, and our final comment.
Yeah.
Please introduce yourself.
Yeah, my name is Grace Kihage. I am a doctoral student. I have also, Oscar is my colleague. I come from Kenya, and I'm happy to have interacted with them in the research. I wanted just to make a comment. I want to edit a little what he has said. It's about the payment of the community health volunteers. As you realize that he said it's about 35 actually to be specific, euros per month. So I feel they still need for more partnership, because to me that's a small package for the kind of amazing work that they are doing. So there's still more room for partnerships to make sure that they are getting a little more support for what they are doing. So there are a lot of studies that have showed that a lot of community health volunteers are lacking motivation because of these kind of small things. So where there are rooms for partnership, I think we really need to lobby for them being supported and get much more than €35 per month. Thank you.
Thank you very much. So, thank you so much. We've gone full circle. We've explained the role of malnutrition, community health systems, and community and societal engagement, and ending with saying that they are so critical to the success of malnutrition. Even with this innovation, it is the community, the health workforce, the community health workers who are 70% women who actually make the success of this delivery. And now finishing up with that point that they need to be paid decent wages, at least minimum wage. Thank you very much. Please a big hand to our panelists. And to you as well, thank you. Thank you very, very much. Enjoy the rest of the day and the rest of the WHS. Thank you very much. Bye-bye.